whether it be possible to do just level 1 without sampling, or we go proceed to the relaxation. So my center so far we do as relaxation, but to reduce the morbidity, right? So for the follow the guidelines, so we still proceed to as relaxation. Is it possible for us to proceed the level 1 not sampling rather than AC? Yeah.
So in my practice also like by default, because our concern is you can see that seminar biopsy can be resident parents. So by default it's resident parents at this moment. Follow the CB.
Topik. Sebab tunjuk otak-otak lah Vincent.
Cancer, for those who are negative lymph nodes on imaging. So if patient receives a neoadjuvant and after the neoadjuvant is still negative, so I will proceed with the sentinel lymph nodes. But still, I use a single method. Because if there is no, based on the studies, but I can't remember, the retrieval of the sentinel lymph nodes biopsy in a virgin breast area is admissible.
So I think there are very important points here because of the Amaros trial. Sentinel trial. So what the Sentinel trial plan to do was actually to see whether you can actually do sentinel biopsy after the adjuvant treatment. So there because of, you see when you all especially the trainees, you must know these two things: false negative rate and identification rate. So what you want is a false negative rate of less than 1%. Okay, fair, that is acceptable, right? So what kind of methods you make sure your false negative rate? We are the dual methods, and so when you do the adjuvant treatment, it's better to use dual. So sometimes all of us in practice that I do dual effect. So you are a bit torn. Should I attempt? Because you know you can get false negative. It's up to what? I think it's like 20% false negative rate. It's the method for the Sentinel trial. So you have to choose well. And even if let's say someone gets a complete pathological response, maybe those are the types of patients you might want to choose now. If you have actually a lot of times you do measure for scans, right? And the tumors are small, right? So in those situations you get the type. But then again, if you support this unit, okay, extra witness, put your finger on the tonsillar bed, stop the bleeding, and you are the tumors. Okay, that's the people all really yang faham, you faham.
For the negative, from anti-negative before, anti-negative lymph nodes before we initiate the, for those who are complete response, we make sure patient of
Adjuvant still, I didn't need the sentinel lymph nodes post neoadjuvant. Only negative, small tumor, negative lymph nodes. So I proceed with sentinel lymph nodes biopsy post neoadjuvant. Especially for those who are 2 centimeter tumor negative, HER2 positive, we give the targeted therapy. And if still no nodes, then because I proceed with sentinel biopsy.
Sampai Sarawak itu belajar buat targeted axillary section kan? Actually all know what it is.
Good morning, everyone. Today I'll start with the case discussion for young breast carcinoma. Can you all hear me? No? Can you hear me? Okay. Closer. Okay. The first case is a 30-year-old Malay lady with Gravida 2, para O+1 at 35 weeks with GDM. She presented with 2 months of left breast lump. She had an ultrasound done at private, there's suspicious breast lesion, so presented to us 2 days later. Risk factor, she had a menarche of 12 years old. And then her maternal auntie had breast CA at 40 years old. Next slide. So on clinical examination, there's fullness over the left upper quadrant of the breast, about 7 × 7 cm. There's non-tender, there's no actually liminal palpate. It's a pregnancy, so the breast is engorged. It's difficult to palpate a very well-defined lump. So right side, there's no any lumps. Okay. I think this slide was
In the interest of time, I think,
okay. I think this is the old slide. This is not the latest slide.
that's the
Okay.
sound.
Wait. There's another slide. I sent you to WhatsApp, right? Just now. Yeah. Sorry, I have another slide. Yeah. Sorry. I sent you the latest one today's morning. The one have a separate ultrasound picture. Yeah, go next. Okay. Okay, this is the ultrasound done. So hello. Anyone would like to comment the ultrasound?
Right, Richard? Thank you.
Cheng is in fine.
It's a regular populated
Yes, correct. Okay, so this is the lesion as he described. It's a suspicious GRAS 4B. So we proceeded with biopsy. So next slide. So it came out as invasive CA, ER/PR positive, and HER2 negative. So now the diagnosis is Gravida 2 para O+1 at 35 weeks with left breast invasive carcinoma, clinical staging T2 and not ER/PR positive with HER2 negative. So how will you manage this patient? Anyone? Go back to the slide before. Next person, anyone? I think we went to the next. Okay.
right. So we have patients at 5 weeks of pregnancy. So I think this one we have to take into account a few things. I think we can talk to the FMED, maybe talk to our OMG colleagues and also our POD colleagues. We have to understand what are their threshold for their management, how early they can manage premature delivery, because it will help us decide when can we induce the pregnancy for the surgery, or if they need some time to reach the maturity of fetus, then there is also option of starting chemotherapy prior to delivery, and then subsequently followed by our certificate.
What do you do? What
I
do
think
you
for
arrange? I mean, when you are managing this, what do you arrange?
we arrange for MBT. I think that's the most important. Yeah.
Who you call for the MVP?
As I mentioned previously, I'll get our OMD colleagues involved and also our electric and utilities involved. They are the important in managing the frequency. If you need to reduce the level for frequency, we need expert. Objective recognition, right? And also our neurologists. And also our
Sorry.
So,
Because I think the initial presentation included the 7 centimeter mass, and the ultrasound showed about 2 centimeter lump. So there is a clinical and radiological discrepancy. Would you consider other ingredients to?
what do you think?
I think she's certified because so it's safe for mammography. Because maybe it's rather with the staging, you may change, and in terms of later on, you want to know whether the mass is actually the 7 into mass, whether there are any other masses which is not seen on the ultrasound, and whether we can do a breast conservation on the surgery or transplant.
It's very funny. You think by doing that you change your management at that moment?
At this point, but also there's a discrepancy between the clinical findings and the
Because as you know, the breast in pregnancy is not the normal breast. Usually it's doing eclosion. The clinical findings differ from the original. But the thing is, she is certified with. So for me, I think the breast is visible vision, and you can do all the investigations they want, and breast scan after the delivery, because you are not going to give anything to patient. As you're talking more that it change the progression or the size of the. So the next one.
Okay, then we had MDT. We agreed to induce at 36 weeks, stop the breastfeeding post delivery, and then for mammogram CT and breast marker after delivery, and for 6 cycle of neoadjuvant chemo 2 to 3 weeks after delivery, to start Zoladex after delivery, and for genetic testing. Post-op, we plan to assess again. So the progress.
Any comment? Okay, how about oncofertility issue? Because this is 30 years old. For people, for future, that's once you give chemo, you already. What do you think? Oncofertility. Yeah, we should also involve the oncofertility in the discussion. She's pregnant and she's post delivery. What's the option? Maybe we can preserve the oocyte before we go for chemo. What kind of preservation that you want? This is you can go for oocyte tissue cryopreservation or oocyte during after postnatal. I think at that time we are. Or discuss with the fertility about this. I'm not an expert. I think it should be discussed. It should be an idea. What kind? I think in the list there is some authorization. Which the NHRH, right? Yeah, that's why during the chemo, yeah, it should be in the discussion. Okay. That's what we are going to ask other things. But any just want to comment about the breast. Yeah.
Session. If I miss, I miss it. Is it in RPR positive, right?
Yes, yeah,
It's a tumor. One time they put the upfront surgery better than one different.
It's a bit because we haven't, yeah.
They don't have.
In RPR positive, record negative.
But because maybe, the 7 centimeter.
Oh, it's a, I think,
7 centimeter in the clinical setting. So
oh,
we haven't done the mammogram, that we should go first. And, since I think, 7 centimeter tumor.
oh, 7 centimeter, oh, I thought it's T2 tumor, T2 tumor,
Imaging. Pregnant.
So you nak makan yang mana? Ini ultrasound.
I think, Adiba, I think I got what you mentioned, but I think what is the most important here is we have to decide from the breast imaging. You can see only mammogram and ultrasound being done. And clinically, you can feel a 7 cm tumor. And what you should confirm is, I suppose, the MRI price would be best, main option for this patient since already delivered. So you will know whether this is really T2 tumor or is it 7 cm tumor. If it's 7 cm tumor, I'll also not going to do mastectomy as what just
Because it will help to different our management kan kalau let's say
But still, if you think, because if you feel the 7 centimeter tumor, when you put in, you cannot pick up.
okay, that one I agree. Tapi I won't put CT2 lah, I will put T3 to be advanced.
Tapi I think Adiba has a point because when you treat a patient, you have to treat the biology of the tumor. So I think yesterday somebody asked what is Ki67 going to be helpful? So in this case, great will be helpful, Ki67 will be helpful. Because for all you know, sometimes when you give the adjuvant chemo to someone who is ER positive, you might actually do harm to that patient because you do not respond very well to the chemo. But if there is any indication for systemic therapy in a hormone receptor positive patient, like node positivity, or really locally advanced, actually you tak sure kan 7 cm tu locally advanced ke, or maybe just breast tissue changes. So MRI ni kan, the problem with MRI is how fast are you able to do it? Because sometimes it delays the treatment a lot. But if you can get it, why not? She's 35, she's got a family history, and then she's got dense breast, and she might even be a carrier, or you know, right? MRI will help to also determine the other side. But only if you can get it early. Do not be fooled, wait for MRI like 2 bulan lagi. Do not do that.
I think in HDL we have contrast enhanced digital mammography. There is another option because we have to know this is very dense breast. I think you won't be able to see whether this is really T2 tumor or is it locally advanced tumor.
Next.
Sorry, Ms. Ju, can I just clarify something? So how do you stage this? Is it a CT2 or
Clinical
treatment. The clinical staging will be copied at 7 a.m. Regardless of the imaging showing that we still go by, I go for
T3. Then this patient delivered by LSCS last week. So we plan for mammogram and CT staging next week and breast marker insertion. So oncology plan to start chemo 3 to 4 weeks as she's have a Caesar wound once it's healed. And they will stop breastfeeding with bromocriptine. So that's the first case. So I'll go to the next case. So
we have 3 cases.
So this is a Mrs. N, 34 years old Malay lady with no medical, presented with left breast lump for the past 3 months. She attained menarche of 15 years old, married with 3 children, breastfed 2 years each, just delivered a month ago and still breastfeeding. Her maternal grandmother and maternal aunt had breast CAA at 40 and 50 years old. Next. So clinically, there's a lump palpable 2 × 3 cm at 9 o'clock, hard and slightly mobile. There's no axillary lymph nodes. Next. So anyone would like to comment on this ultrasound imaging?
Okay, this is the ultrasound of the left breast. So you can see there is a heterogeneous lesions with fairly regular margin. And then the center is a hyperactive. Maybe there is a bit calcification, I can see. But from that, the size, right? Yeah, 1.9 times 3.4 centimeters.
Okay, correct. So she have a similar lesion at 7 o'clock. I'll just proceed. So there's multiple breast lesion. So we proceeded with a biopsy. So it came back as atypical SEN with background of lactating breast tissue. So how will you manage this patient? Anyone?
Anyone? Adi? Of course, you want to identify the biopsy, but unfortunately, the appointment for the ultrasound guided biopsy is quite long, and because of the breast mass is quite large, so we don't want to wait until it comes to progress. So we decided to do excision biopsy. Quite okay.
So we proceed wide local excision. Next slide. Next slide, yeah. So the left breast at 7 o'clock, there's invasive CA, grade 3. The anterior and inferior margin are involved. The laminical lesion, invasive CA as well with grade 3, there's margins are not involved. So it's a triple negative breast CA.
Okay, next. Okay.
CTCN, there's no distant mets. So next.
Okay.
Because I think we haven't looked at the imaging for the breast. So ultrasound again. Maybe a mammogram, 30 years old.
Yes, 34, yeah.
Yes.
A mammogram, and then possibly an MRI to assess the breast, look at the other breast. So, and then because she's a young patient, consideration for genetic testing or mobility as always. Because so if the genetic testing is positive, because I think on the left breast they require a mastectomy, possible reconstruction, and then we need to think about the other breast genetic testing is positive.
Any other management?
Oh, sorry, and we haven't done that, so we need to manage the large assembly.
So you will directly go for surgery for the mastectomy as well as the section.
So it's like different times. So this is
Why look?
So multi-century disease of this type and they go on, so for this breast will need a mastectomy, with possible reconstruction.
And then because she's very young in the family history, so genetic testing, if I can get that 4, so that I can counsel regarding the natural breast.
Kadang yang masa masuk buat local, when we go in for buat local, we put it in the jumpa bag, we put it. Okay, tak ada. Jumpa itu biasa lah kan. But I just wanted to clarify kan. You all should know that ultrasound was suspicious. You need to know how to even describe it in your exams, if not fail, okay? Because you look at this, does this look very suspicious to you? Is this virus 4 or 5? Likely to be 5, isn't it? Tak adalah, I mean, we can't tell. Okay, so she's 34. Should you do a mammogram? Yes or no? Yes. Okay, so I think if you find someone, kan nampak macam you can see the small little microcal, those are microcal. Somebody mentioned a big calcium, what do you mean by big calcification? So you use the right terms. You can actually see tiny little calcification. This is a actually they tengok the heterogeneous lesion. And then you also have what? Enhancement. So possibly enhancement. So please learn how to do this because you're all breast surgeons. Guess what? Who's going to manage this in the clinic to decide whether you need a biopsy? Definitely you all. And do you need ultrasound guided? Also definitely you all. You don't need to have the pathologist do the ultrasound guided biopsy. Cuba tengok area satu kecil kan? Cuba tengok yang ni. Tengok 1.35. Would you do it through a free hand in this case? You would never do a free hand. One time biopsy and that's it. You do the best thing you can for the patient. You get the best. And still sometimes the result will come back like this, right? In that situation, I completely agree what your decision is the way to go. Please do not repeat.
This is the breast. To get
Actually, after some guidance, if you have all of us, all the trainees, you all need to do it. I'm sure you all can. Okay. Workshop. I want to talk about ISW ada buat ultrasound course Yeah, we need ultrasound yang klinik. Apa kalau you high
we ask for ultrasound guided, they give us, but the result of this, then we want to repeat again, with the ultrasound guided by them. We are very, very
almost all dentists are doing their own ultrasound guided biopsy. On this layer, kan? Yang lain, dua lagi. Ada dentists.
Next, so we had MBT discussions.
Then this is considered breast cancer in pregnancy as well, because anyone knows the definition of breast cancer in pregnancy? Someone? Aina? How long after the pregnancy? How long after delivery? Any thought about post delivery? 1 year. So of course we ask for a chemotherapy, mammogram, and mammogram.
Next.
Okay, next. Which
And then she underwent chemo, and then her genetic testing came at BRCA1 positive. Mammogram was just left breast cyst. So what are the surgical options?
what next? Patient had chemotherapy, patient had local excision done. So the surgery is not completed yet. So what are your thoughts? Next to Aina.
Let's go.
Next Aina. Aina tengok belum kontak Aina ya? Stage donation.
Sorry, PDP, is it still possible? Because, on the my surgery. I just
No more,
forgot.
no palpable.
So it's a YCP0N0M0. But the problem with this patient, she's young with a power positive, so the
YCP0, not zero.
there's none in the ultrasound, and clinically it's not palpable. Mammogram is just a 6.
This is the second.
Before the
You know, before the one, look at 2 times 3 cm. T2.
What's the size of the white?
2 times 3 cm. T2. No lymph node population.
Pre-chemo is CT2N0M0.
Yep.
So after the surgery and after the new adjuvant will be YCP0 because he's really unpalpable, and also N0M0.
not probable. That one we have like 5.
But actually my concern was
Before the excision.
you will still want to have a clinical assessment after the chemotherapy. Okay, so my clinical assessment for now is a CT2N0M0.
Okay, how do you calculate the size?
I thought we do. Okay, if it's T, because this is T2, because it's more than
Actually, you have additional information because you excise the tumor, right? So how do you stage pathologically? Can you stage pathologically?
HP post-op. HP
types of
2 times 3 juga sama kot. No, white local same, around the same. 2 times 3 centimeter, around the same as the clinical.
Actually, the 7 o'clock is the
1.5 bigger. 11 o'clock is 2 times 3. The 7 o'clock is 1.5 times 1 cm. The
How do you stage the lesion?
3 cm.
Ada 2 lesion kan?
Yes, yes.
Lesion tu apa size tu?
10 o'clock was 2 times 3.
Okay.
The 7 o'clock is 1.5 times 1 cm.
So how do you do the staging?
So it's a pathological staging of PT2 triple negative.
What is the size of the tumor?
It was 2 by 3 centimeters.
How does the oncologist decide what is the size of the tumor that they use to make treatment decisions? Have 2 lesions kan? So what happens if you have 2 lesions?
They will, if it's a multicentric tumor, if there's 2 tumors, they will take the largest lesion. So that will determine your
Okay, and you can put a prefix of what? When you write down, when you document, what would you document? What prefix?
PT2, PT2, CN0,
And you can ada M juga, ada P, N, which is M, P, M.
it's multicentric, yeah. So it's
Okay.
MP,
So we expect this from you all, okay? You all going to be our pakar payudara, okay? Alright,
Next.
yeah. The Rana one was leading. Then she completed but unfortunately she doesn't want
Any recon, so
So we went for
mastectomy with SLMB and prophylactic mastectomy of the opposite side. Next. So the HP came back as complete pathological response, no residual CA. Lymph nodes was 0. So the right breast was just benign breast tissue. Any comments of the HP compared to the first and the second? At first, that's margin was involved.
Any comment? The thing is, do you take it as big fat CR? I don't know, I don't think it's fat CR, right? But they remove the tumor and we think the margin is not.
Margin
clear.
is,
So I think, when we go in again, we rarely get the margin.
If BRCA aside, let's say she's BRCA negative, she has a multi-centric tumor. It is not an absolute contraindication for us to have the breast.
I don't know, what about, promotion? For Sullivan?
it's a monthly for potential.
It is a multi-centric tumor, but if we are capable of monitoring, if let's say we can do a contrast enhanced mammogram, we will not detect any other lesions in the breast.
I think there was a publication recently, isn't it? Somebody shared it with you. I can't remember who it is. Is it Prof. Mulia? Because actually nowadays, sometimes, especially in the era of neoadjuvant therapy, you can tend to do white local excision for all the tumors, right? You get good margins, fine. You can actually get away with it. Okay, but then in this situation, she's BRCA, so you probably would not recommend. So, but if the patient's like that, even let's say she's BRCA, she doesn't want a mastectomy. Can you offer her BCS?
Yes, because we still have to monitor, I mean, if
But
patients
why can you offer her BCS?
BRCA commanders, but BRCA1 commanders on 20%. So technically at some point she
We have cancer, she has 100% cancer, right?
at some point she will be.
Yeah, but you must have oncological reason why you can allow the patient to have breast fertility. So kalau nak tahu pergi masuk kursus mainstream ni, ada, you have to know whether you can do PCS in BRCA, right? So, yang satu kan, sebab kita belajar pasal education, kita negatif. Bila kita do the white local excision first, you lose that information. For all you know, this patient, kalau you buat neoadjuvant, ada residual tumor. So now this poor woman does not know whether she needed
Second
surgery. And if she's BRCA, she might have needed the PARP inhibitors. So you miss the information now. So I think that's very important for us now to give maximum treatment to our people negative. So people negative is very aggressive. They will recur. So if we lose that information, that's why I think once the time nak buat biopsy tu kena be perfect. Not, you know, itulah, kena beli ultrasound. Yeah.
Okay.
Go back to the definition of diversity. The definition is let's say the patient postpartum, still breastfeeding or second year, then like those with breastfeeding. But as far as what I understand, after delivery, still lactating, still breastfeeding. As far as I understand from the definition that I read, is that as long as the patient still lactating, we still consider as a gestation as a breast cancer.
I don't know, I haven't come across it. I think 1 year after the delivery. I think we can we have another case.
Next slide. We just finish up this case.
Okay,
Okay.
I think this case is very important actually, yeah. So for the sake of the trainees, okay, I would like to twist a bit the case again. Patient non-lactating, provided you have done both biopsy on two sides and dua-dua kata IDC. And you have, okay, should you go for one local excision on both masses ataupun something else? Okay, tanya orang. You understand what I mean? You can diagnose IDC on both now, multi-centric disease. So what's the plan now? What's your offer to your patients?
It's very clear, I would love to discuss with the patient, but if the patient is that kind of people who really wants to preserve the breast, then I will do more investigation like MRI to ensure that is the only two lesion and see what is the breast and tumor ratio.
and see whether I can help to preserve her. But I will, I advise her towards the side of mastectomy.
Okay, now I give two options. One local anesthesia or breast conserving surgery or mastectomy. Which one you choose? What would you recommend to your patient? Why?
Because if the breast is having multi-center, focus on centricity of cancer, it means the other part of the breast is not that stable that we can develop into this cancer at any point of time. And that's why
Go to the family history.
Okay, anybody wants to do BCS? What's the CBT? For multi-center? Okay, so kalau macam ni, tadi dia suspicion kan, dia tak sure. That's why they want one decision, but still margin not clear. So okay, but finally patient has removed the breast. Okay, but you have to follow your CBT. Okay, walaupun patient request, but you need to explain the patient very well. Yeah. I know, people in privates, they still entertain whatever patients want. 4 patients in the breast, they still do one organization.
Okay, last question, ada masa? Okay, you all think about this answer yourself. If her results is BRCA negative, would you still recommend a mastectomy and a contralateral mastectomy? Okay, we can just relax for that discussion.
Thank you, everyone. So, that is very
Discussion. So we move on to our next piece. By Dr. Kuswai, instead of cases orange moderator.
Kita dah angkat. Kita dah.
Assalamualaikum warahmatullahi wabarakatuh.
Oh, lepas ni je. Si BRCA positif lah. Video sebab masa dia datang hari tu dia hantar. I pergi dulu lah, habis lepas ni kita bawa dia pula.
So basically, this is kind of a conversation. So she asked, Doctor, am I going to get breast cancer? What is my risk to develop breast cancer as my mother and sister have breast cancer?
Sorry.
So at this point of time, how will you strategize the patient, please? If the breast is treated, and how will you diagnose them? So, I ask. So, you want to answer that?
So, for this patient, because it's a primary family history, this has the breast cancer, the patient are high risk of getting breast cancer as well. So, in this genetic testing indicated, I think this one, because not familiar in the genetic, for me, myself, I will refer this patient to the qualified genetic counselor to explain that.
So this patient is relating to me and seeing you. Asking you this question. Okay, should you research it without read the counselor?
I think, I can tell this patient,
What are the discussion or the point that you want to discuss?
I will tell the patient a bit about the genetic testing that one to offer what test like the BRCA testing that she can undergo, but give her some idea what's the implication of the genetic testing. If she is tested positive, then the implication of the future treatment, and she might need to all the family members have need to consider the treat as well. That's the implication. But the overall pictures, you need to meet the genetic counselor.
So which hospital?
Now and in UKM.
Okay.
We have genetic. Yes. Okay. We can.
Okay. any other hospital that under this kind of similar situation, how you will counsel, especially in the hospital where you don't have services, where you have to be your own counseling. This is what Pasha is the one outpatient officer.
I have to check, brother, yeah. Our student doesn't have a genetic counselor. So what we will do is we will do a pre-genetic counseling. So the pre-genetic counseling will include telling the patient, first of all, I want to know the patient family member whether they are tested BRCA, whether they are BRCA positive or negative itself. So I will come, she is very high risk, she will require screening mammogram for her to say. For the counseling wise, I will talk to her regarding what is the possible results that can be a positive, a negative, or indeterminate. So as well as then we'll talk about the implications. The implication will include the further treatment that she requires, as well as the social, other financial implications. So that will, if she was tested positive. Subsequently, then we'll tell her that if she keen for the testing, I will refer her to HKL for geneticist to counsel further. Usually,
How do you put this down?
we'll give a call to the genetic clinic and they give a DCA.
Oh, I guess we have to email, no? We don't talk, it's the call.
Okay, thank you for the answer. So basically, for risk assessment tools, there are a lot of them. But there are several that is more familiar, like Manchester scoring system, Tariq-Uzik model, Boadicea risk prediction models, okay? So these are the factors that is being taken into account when we want to try to, assess the risk for the patient, whether the patient will have breast cancer or not, and whether we want to offer the patient for genetic testing. So basically, like what Janet mentioned earlier, so we have to get full family pedigree. We want to discuss about the benefit. Why do we want the patient to undergo genetic testing? Okay, because we can actually reduce the uncertainty about cancer risk. We want to reassure the patient if the patient turn out to be negative, but patient has to understand that there are risks, some risks about it also, especially involving psychological, social, okay? And there are some limitation on genetic testing because it may not provide definitive answer, and it will cause significant psychological impact. And there, as we all know, there is possible genetic discrimination, especially in insurance claim. So basically, this is the family pedigree of the patient. So on the right-hand side is the maternal history. So as you can see, the mother is being diagnosed with breast cancer. This is the mother. The sister of the mother means the maternal aunt is also, the maternal aunt was also diagnosed with breast cancer at the age of 60 years old. These two aunties died early due to some sort of cancer. She was not sure whether that is breast cancer or not. Her sister is also a breast cancer patient, and she has another sister, leukemic patient. Okay. So this is, as an example, Manchester scoring, just for exposure. So we do Manchester scoring to assess whether this patient is high risk. So for my patient, so she has a family history at 45 years old, the sister, so there is 6 marks there. So the aunt and also the mother was diagnosed at the age of 60, so another 4 marks here. So a total of 10 at this moment. But we have another 2 aunties who died earlier, right? So we are not sure, probably it is more. So in Manchester scoring, if the scoring is more than 15, patients should be offered with genetic testing. If the patient came to us already being diagnosed with cancer, so we have to see the tumor biology, and we have to follow the adjustment, okay, whether it's plus or minus, we can see here. So this is a long list of NCCN guideline who to choose, who are the patients, to bring for genetic testing. However, it might be a bit of not cost effective. So our CPG already summarize and simplify the list, like this one. So like this patient, so the breast cancer plus parent, sibling, or any child, okay, means any family history lah, first degree family history. So she's actually indicated for genetic testing. So back to our patient, she revealed that she went to private and undergo ultrasound. So anyone wants to comment on the ultrasound? Dinesh?
So when we find calculate lesion, usually 0.57 to 2.4 centimeters and
Okay,
this is best.
breast cyst. So what is the BRAS, do you think? BRAS 2?
What is your plan based on your description?
So this patient is copy 5 years old. So we will see the mammogram for her.
Okay, what do you want to do with the lesion? Do you want to do anything, or you just,
It's a benign small lesion, so mammogram there's nothing, so I do surveillance. And she's a strong history of familial breast CA, so we have waited to genetic for genetic.
Anyone else that have doing good? You want from the whole, or the
We have facility for trust enhanced memo. This good idea to do trust enhancement. But the issue is sometimes application of the contrast and memo from what the input I got from preferentiologists, our preferentiologists. I think that they have the breast cyst sometimes they can have difficulty to interpret, but obvious lesion is no issue. Contrast enhanced would be fine.
Or what information, additional information you can get from one-time maintenance?
It is pretty compared to the conventional mammogram. Sometimes they can receive non-mass enhancement, which we cannot be seen.
Some differentiation is only a hard one.
I can't remember the specific characteristic on contrast enhanced for this case, but probably it's benign and it's self-enhancing.
okay. So I agree, we will proceed with mammogram. Whether wants to biopsy or not, basically this is a BRAS lesion. Looking at the features of the lesion itself, close surveillance is actually enough. BRAS 3. It is an probably benign because of it is regular, oval, hypoechoic. There is no heterogeneous, no irregular. Yeah.
Remember, the radiologist does not care about the
Family history, yeah.
about the family history.
That's right. Okay, so the first thing you do, this patient is, what's the category of risk?
High risk.
She's high risk, isn't it?
Yeah.
Based on, purely on the family history.
Mm.
So you already, okay, this is high risk. That's your people assessment, yeah. Clinical assessment, she's high risk. Imaging, benign or not benign? Benign looking, right? Okay, does she have a previous image to compare with? No, so how are you sure that this is not something malignant? So what is the percentage of malignancy in a BIRADS 3 lesion?
It should be less than 2%.
It's about 5%. Okay, right. So BIRADS 4?
Whereas 5 to 20%. I mean, depends on 4A, 4B, or 4C.
Okay.
If 4A is 5 to 20%, if I'm not mistaken. For 4B is 20 to 70. For 20 to 75. And 4C is 75 to probably more 90%. 90 to
So
95.
you must that concept that the thing that is benign can actually be malignant in the rare situation. Okay, what would look like this? If the patient is a BRCA carrier, do you think the imaging could look like this? What type of tumor can look like this? Orang jawab lah, siapa nak jawab?
Tadi. Ini potential executive.
Sorry, probably for business type of cancer, because sometimes we can appear as a system.
Okay, what is the subtype that is associated with BRCA1 issues?
The triple neck was the other one. I think triple neck.
Medullary, yeah, betul tak? Medullary has Cushing margins, can look exactly like the fibroadenoma. So, all of you wanted to do surveillance, tak pass lah exam. No, really, because this is serious. You know, it's probably virus because you have nothing to compare with. The range of having a cancer is there, that is a rarity. But her risk assessment is she's high risk. So, what would you do in that situation? Would you call it a virus 3? Even though if your radiologist put down as virus 3, what must you think? There's a discrepancy, isn't it? She's high risk. And this is a very benign looking, but then there's a discordant. You need to biopsy. Betul?
Betul. But before we did that, actually I mean, back to the genetic counseling, she was not ready for it because she was afraid that it would affect her insurance, so it was not done. So she actually came back 3 months after that with big mass 2 by 2 cm at 1 o'clock. Periareolar region is actually a different lesion from the previous one because the previous one was at 9 o'clock. So around 1.5 centimeter from the nipple.
So I have a question.
Okay.
You recommend genetic counseling?
Yes.
Anybody wants to answer this question?
Whether we want to offer the
Dia
counseling.
nak tanya
Ya, ya.
genetic testing kan?
Dia nak tanya dia punya risk.
Recommend that she go for genetic.
Yeah. Definitely, because she's high risk. Now that.
So the other principle in genetic testing is the best person to test is the person who has cancer and affected individual. It's better to test in those family members rather than because what will happen if it comes back negative? Is she high risk? She's still high risk. Okay, you all need to know that if it's BUS, is she still high risk? She's still high risk. So usually we do it in the patient who is
Already diagnosed.
cancer.
Okay.
You can still do. You can still do because what happens in the lab is that if the patient has no macam history of another family member, they will do what they call the gene search. Basically, they do the whole thing, the whole genome. They will look for whether there's any abnormality, any pathogenic variants. Okay, but if let's say the family member has had a test, the test that you send for the lab is no longer the gene search. You don't need to do the whole gene. We call this predictive testing. Therefore, you need to get the history from the family member. The lab result is good to have it so that when you order the test, it can be cheaper. Okay, and if you do it with Cancer Research Malaysia, because it used to do dengan DBT, the company, any predictive test is free. So if you have an index patient and the family members who nak buat predictive testing, it was actually free.
True, that's very true. Thank you, Prof. So this is the mammogram. Okay, they have been reminding me for so many times that we have no time. But okay, there is a speculated lesion here at 1 o'clock, consistent with the big mass. Okay, so this is to compare. Sir, please, I go forward for a while. Okay, this is actually the ultrasound. Okay, this one I want someone. Rizal, can you describe the finding? Huh? Move forward, sorry lah. Okay lah. Okay, just just to mention the measurement here is 1.2 times 1.1. It looks suspicious, of course, and we proceeded with ultrasound guided Chuka biopsy, came back as invasive breast carcinoma, luminal B, HER2 positive. So we want to recap back. This is a young lady with strong family history of breast cancer, clinically T2 and 0M0, but radiologically it is 1.2 centimeter lesion, ER/PR HER2 positive, and refused for genetic counseling. So what is the next step at this moment? 9 o'clock, tak buat.
Second year or third year,
It's so this is the HER2 and genes disease examinations. CP2, we can also offer her, I would offer her a neoadjuvant chemotherapy with breast marker prior of starting the neoadjuvant chemotherapy. So to achieve better PCR, to have a better rate of PCR in her.
what is your certificate on that?
Okay. This is at the upper inner quadrant, right? At the
Yes,
two
yes.
o'clock.
Yep.
So, if this is, okay, again, I would, the genetic counseling,
Or you offer another?
okay, it depends on, I would like to know whether she has a rough.
Marker, you need breast cancer.
Yeah, I forgot about the genetic counseling, whether if she is a BRCA positive, I would emphasize a bit regarding the genetic, that would actually impact the surgical management. If she still refused of doing a BRCA, a genetic testing, so I will counsel her and give regarding these two options. In view of a high risk background likelihood, she probably have BRCA. So she if she's still keen to conserve her breast, then I would offer her a breast conserving surgery.
If you may have one more candidate to answer this question. Anybody that has different approach or different opinion?
From what they're saying here, she's positive. Yes, she has a high likelihood of being but he also has a previous sporadic family hereditary breast cancer. So, I would say, I'm not eliminating the BRCA part, I would say counter for genetic counseling. But if she refused genetic counseling and we do not have any proof of BRCA, I would just treat her as a sporadic, familial breast cancer. I would still like to offer her breast cancer surgery. And at the same time, since she's high risk, I would follow her up closely. I will give her new adjuvant. I will put a marker in, still give her new adjuvant and aim for breast cancer. But of course, during the discussion, I will also offer her the mastectomy if she's keen, seeing that we still have a risk of breast.
Okay lah, okay, but okay, so actually we did re-counsel her for genetic counseling, but she still refused anyway. Okay, about new adjuvant therapy versus surgery upfront, this is radiologically T1B. It's just that clinically is T2. So probably we want to go for surgery upfront first. And then we want to discuss patients further because this is ER positive also, so ovarian suppression and also fertility preservation. Even though she's 45 years old, we know that the ovum is getting less and less, so we have to ask about that. And the options of surgery is as being discussed just now. So this is basically the sorry, Prof. Betul, MDT. Okay, minta maaf, thank you for reminding. So don't forget MDT. So basically, the slide is to show you the path, the common paths. Whenever we all refer to genetics, so it is good to know whether patient can self-fund or cannot. Because cannot, it will go to the government lab, in which we have to wait for 6 months. Whereas if the patient can self-fund around 350 USD, probably if convert around 1,700 like that. So it can be as early as 2 weeks, okay? Especially if we want to get the result urgent, because like in this case, we want to know whether, we want to do risk reduction surgery to the contralateral side, okay? So patient still refused. Okay, back to the surgical option just now, like Mr. Rafiz asked. So those are the things that in our mind, right? BCS, Mastec, and SLMB or Mastec with immediate recon. So for this patient, she actually requested for prophylactic live mastectomy, the contralateral side, even though she was not proven to be genetically positive. So I want to ask whether it is justified. And if yes, how do we justify? Anybody wants to answer that? Kak Ismas?
We don't do BRCA testing. We cannot do prophylaxis and mastectomy because we don't have any reason why we remove the normal breast. So yeah, I think that's pretty controversy. Before you confirm that this is a positive sample.
I have different opinion. Yeah, I mean, in the best situation, positive and BRCA should do probably mastectomy, but because of other reasons, like patient, the psychology and also we will want to get away. So with she's being in high risk group, having 2 first degree family member having breast cancer. So highly likely she also have BRCA mutation. So in this case, the patient request, we should understand this option. We can proceed with prophylactic mastectomy, contralateral with
Do you want to do anything before going for surgery? I mean, how do you justify? Just by asking, are you sure? Are you sure? Or you want to do something else?
This is done after thorough imaging that we can just stop. normal memo, sound, or whatever.
Everybody is being property. How about your practice? You encounter a lot of patients, I think. Would be choose to do a genetic testing.
Yeah, I think, what we have experienced before, some patients actually request for prophylactic, mastectomy. Yes, it's easy to decide, but you have to know the complication or the sequence after the mastectomy. Patient might, initially was feeling that, okay, just remove everything, but then after that, you feel that, oh, I'm no more feminine, because there's no more breast. So what I think, we supposed, as a surgeon, we supposed to refer this kind of patient to our psychiatrist to assess whether this is really her decision and she aware of whatever complication, or whatever sequence from her decision. Yeah, we are with that.
I agree. I think you need to have a third person involved in the management rather than you and the patient, because you can, depends on how you discuss the patient, you can divert to whichever plan is.
Yeah, I think then you have to think of it like this. This patient, based on the family history alone, she's high risk. Whether you do the test or you don't do the test, she's high risk. And then she's got cancer somewhere, right? Very rare, like people get a passport already, but then you're very, can happen very also. So even as you don't do a test, you consider her as high risk. You as a resident can actually offer her and recommend to her the option of the contralateral prophylactic. So don't be scared, because this thing is macam, you don't have to have confirmation. Because guess what? Nanti you do a genetic test, semua negative. She still have the excess risk based on the family history. She is high risk. So you as a resident, you can offer for her to mitigate the future risk. Okay, so I think it's a little bit scary. So that's why some memang betul, most of the time when we don't have, in fact, in the patients yang bukan BRCA, most of the time they end up with the psychosocial support. Dan psycho-oncologist lah, who will talk to them and then clarify. But even after that, your patient can still get depressed again. So if your patient tells you, oh, I'm not emotionally attached to my breast, they get depressed. So be prepared and make sure you are able to refer to it, because patients have a lot of psychological morbidity. Okay, but it's actually up to us as residents to determine this and to recommend what else she can do to mitigate her future risk. But let's say patient is stage 3 or stage 4, you will not push the prophylactic treatments until you know that the patient is going to be cancer free. Okay, because BRCA is a good thing sometimes, but they are very chemo sensitive. So they actually do well. So patient stage 3 and itu 20 tahun masih ada. Itu yang kita cancer satu ya. They actually do well even in the stage.
Also beware of medical complication, implication. You want to raise your insurance to what? 4 million or 10 million now? Because 1 million is not enough nowadays.
The discussion is a shared decision making, right? So your documentation is extremely important. Even if a patient has BRCA, you don't just say, okay, you have to remove your opposite breast. You cannot say that because it is not disease. It is a high risk breast for future cancers. So after you counsel patient, you have to go. And then how you counsel patient? Silalah buat kursus mainstream. No, betul. I can see that. Actually, we also put the research because that course is meant for resident, for oncologists, because this is what we face. We have to do the risk management. We're not geneticists, we're not genetic counselors, but now we can become genetic counselors. Sometimes. On top of your surgical management, you also can counsel and test the patient. Okay?
So thank you, Prof. Shaniza, Prof. Aisha, and also Ms. Aina for the input. So actually, she was sent for psychiatric evaluation to see the psychosocial background and everything, and she was really, really confirmed about that. So what we did was, right nipple sparing mastectomy. Remember that the lesion was quite near, around 1.5 centimeters, so we sent for frozen section of the right retroareolar tissue, came back as negative, so we proceeded with the nipple sparing. And SLMB on the right side plus implant. And for the left side, we do left nipple sparing mastectomy and implant. So the HPE came back as invasive ductal carcinoma grade 2. On the left side, there is no malignancy seen. Margin all negative and lymph node was negative as well. So basically, this is the immediate post-op image of the breast. So I think that's all from me. Thank you.
So in the meantime, we have foods outside for the tea break, so you can take the food and bring inside. But at the same time, we're going to continue as well with our next case by Dr. Nurul and also Ms. Juliana.
Bismillahirrahmanirrahim, and a very good morning to everyone. So I'm going to proceed with my next case presentations. So I have one patient, Miss B, 34 years old, single nulliparous, presented to us 2 years ago with a painless right breast mass for 3 months, gradually increasing in size with no other significant symptoms. She doesn't have any family history of malignancy, neither taking any history, HRT or OCP. So on examinations, right breast, there is a mass at the 2 o'clock position, 5 centimeter from the nipple, 2 times 3 centimeter, firm and mobile. There's no other signs. Left side is normal. So she came with the ultrasound which was done in private, showed well-defined and adequate lesions, 1.4 centimeter at 10 o'clock position. Then on the left side, there is a well-defined and adequate position with measuring about 7 times 1.4 centimeter, 11 o'clock position. So impression with bilateral breast cyst and left focal lateral adhesia. Plan to see her in 6 months' time with repeat ultrasounds. So she came back to see us with an ultrasound 6 months later, showing larger, well-defined predominant cystic lesions with solid component at 12 o'clock position, 3 times 6 centimeter. On the left side, there's an ill-defined hypoacute lesions, 11 o'clock, 1.4 centimeter. This is scored as a Barrett's 4 for the right solid cystic lesions, and the left hypoacute lesion was suggestive for follow-up. So we did ultrasound guided biopsy, turned out to be chronic granulomatous mastitis, CGM, with the focal cluster of atypical cells. Anyone? So I know, right?
In the biopsy, it proved that it's a chronic granulomatous mastitis. Consider cause of steroids when it's over long term. But I'm still a bit worried because they mentioned that it's presence of atypical cells.
Yeah, what do you want that? At the CGM, are you going to take the biopsy? Are you going to?
It is already a ultrasound guided biopsy, and there's very much because I will also consider what local excision.
Which one are you going to do?
It's a lesion of Google.
Yes.
Yes. Sorry?
This is 6 months later. I mean, the first time she presented. Now she came back with the, oh, sorry.
Not guided biopsy is, yeah. This kind of patient, right? Okay, then, the patient does not want physical biopsy, excision, bigger excision, so we pick as CTF.
Unfortunately, she defaulted as she went abroad. She came back 6 months later with a larger right breast lump. Clinically, it's about 5 times 5 centimeter at 12 o'clock position, soft to firm. On the left side, there's no significant findings. And she came back with the ultrasound, which was previously planned. Anyone wants to comment on the ultrasound? Cheng?
These are also right breast showing irregular margin or heterogeneity is wider and taller, and so as there is a serious schedule. So this is a very suspicious lesion. We ask for B or C.
Yep.
I'd like to
You're talking about which lesion? The one that there's a square inside. It's not that one.
yeah, outside is a cystic lesion.
Okay. So it's
The cystic lesion itself, is that thing is the margin is regular margin, so the viral is not complete. That's the last cycle. But it is the soil component some.
So the radiologist reported as a well-defined predominantly cystic lesions with a solid component, which was increasing in size from previous one, as well as the solid component within. So there was the echogenous debris also seen, and there is now wall thickening measuring up to 8 millimeter with internal vascularity, and the axillary nodes on the ipsilateral side, there's a small sub-centimeter with a preserved fatty hilum, and the impressions now is Barrett's 4B. The left side, otherwise, with the previous hypochoric breast lesion, there was an unchanged. So repeated biopsy, ultrasound guided biopsy shows it's a necrotic tissue. So we started again with the oral steroids with tapering dose. However, she stopped it herself because of the side effect that she has. And at the same time, she has increasing right breast lump, which was reviewed 6 months later. See, she came back with these features clinically. Right breast cystic mass 10 times 8 centimeter, covering the whole, almost the whole breast, especially upper quadrant. There is no skin changes. It's still mobile, and axillary nodes was not palpable. So and the left side as well is no significant findings. Any thoughts at this point? Dun tak datang, Datuk. Dun tak ada.
Looking at the patient's right breast, it's a huge mass with stretch of the skin shiny looking. So looking at this point, I think it's more like a benign in nature rather than malignant, because there's no infiltration to the skins, considering that the mass has been there for so many months. So I think at this point, it still could be a CGM.
It's the allergic, you cannot cope with the, what? The
Oral steroids.
There's no steroid.
First I was explain to her that CGM is a complex management. And if we do the surgery, there's a possibility that the wound would not heal. But because it would not tolerate the steroid, so the option for now is surgical incision. But as I must make sure that she's not the complications after the surgery, like wound will not heal, SSI, and things like that.
Any other take up, Teo?
So, I think at this point of time, we adopted steroid therapy for a certain amount of time. And we have a mass that's steadily increasing in size despite our treatment. And I think on imaging wise, we really noted that the blood participation also is increasing. I think we have to, at this point, decide that this will be something more than just general venous vasculitis. We can offer, I would actually offer surgical treatment prevention. We can actually attempt an excision biopsy for her, right? To actually identify for more of a diagnostic, for diagnostic purposes, to see what it is. But of course, if it after we biopsy the negative, or we have biopsy again.
We biopsy, we repeated the biopsy. It turned out to be necrotic tissue. Second, this is the first one. The second one is necrotic tissue.
So I will still proceed with I will say maybe a wide condition. Proceed with.
How do you feel about the
I think the regular breast isn't that much. Yes, excision biopsy.
Yes. Okay. I think that when you excision biopsy, local excision.
Because we still suspect CGM or distribution and she has allergy to the steroid, so we can try MTX. Another options, because we can shrink the lesions. Let's say the MTX doesn't respond well, so then we can also use surgical CGM. We still have options for steroid.
Yeah, I have never tried to fix it myself.
You have experience in that.
But I think with the still steroid. Okay, we actually.
So we have revised back our diagnosis actually because of the symptoms is keep increasing in size radiologically as well as clinically. So this could be a possible of malignancy.
Every time we do biopsy, we experience about 400 cc. So we try to get the mass, but unfortunately, necrotic tissue, different cells, no mass.
Again, the cystic mass is lesion is getting larger and larger. As Ms. June mentioned, we have repeated again the ultrasound guided biopsy, in fact, twice. Image guided ultrasound is always ultrasound from. Okay, it's a radiologist. In fact, the second one is one is doing their visiting breast radiologist who did it together for the fourth one.
The radiologists that we have, for thinking about Aisha, you know, actually radiologist stress. They probably take so many samples because they know this will be important. So maybe, you know, even the breast cells, you cannot get the diagnosis. So it will be, you know, this is the I don't know, we have tried about 5 times.
Yeah, in total.
Still nothing, it's just it is a big issue. So we have to, yeah, we have to agree for the excision biopsy. Incision, we excise, but during the operation, the fluid, yeah.
Aspirated and
the rim of tissue around it. It's a medullary.
okay,
The
it's
medullary is a little tumor, about 10 cm. And
triple negative.
The big margin 1 mm and the rest is 2 mm. So, what's your comment on this medullary? Medullary injuries.
The size of the tumor, is it including the 60 division of?
yes. Yeah, like together. So this is a ruptured. This is the, if I may point it out. This is a capsule ruptured during the operation intraoperatively. So we try to preserve, but then it's already. It's a 110 is solid component. Solid component. We took out the specimen is about 110 millimeter.
It's not, so
We-
unfortunately, we have asked how many patients that
Yeah.
Because of the excision too, they are reluctant to do excision to this fluid. I mean, the decision to the excision, I think I would really like. It's not easy to decide on the excision because of the, you may end up nak buat mastectomy ke kan? Buat mastectomy
Actually, now I think wanita di luar sana, like huge fibroids, you don't know if it's fibroid anymore, fibroids, tapi tak nak mastectomy. So you do a diagnostic procedure. You don't need to have the margins.
Yeah, exactly. That's why I go for excision biopsy. Just to excise whatever. But unfortunately, when we remove the tumor, when we remove the fluid, sugar base, so we just get a 1 week.
So I think the big message here is, if there's any those cells, you have to have a high degree of suspicion, and then it's a diagnostic procedure. You might not even you may not even excite eventually. But in this case, it's been delayed by what, 1 year actually. 1.5 years.
Yeah.
The prognosis has changed.
Then I think about 1 year.
I just want to ask, before you embark on this, you have aspirate 5 times.
2 times.
Ada biopsi 5 kali,
5 kali before, 2 times before it goes.
but you did aspirate 100 cc. Fluids, what happened to the fluids? Did you send for cytology?
Yeah, we sent. It's nothing came back.
The cytologist is cytoscreen and everything.
Nothing there. We sent even a cyto for CNS, nothing grew.
I just want to ask, if this patient go back to other centers and then get diagnosed by other center, and then at the same time, CT scan show there is metastasis already. So if she are not happy with the first hospital, and then want to further sue or something like that, and if they are called for Aisha to support, are you going to say that the post hospital basically are delaying the diagnosis by not doing the excision biopsy in the first place?
The expert has. But if you look at a case like this, if you are a blended person, it is a bit. Definitely, if you become self-diagnosed, okay, CGM, you rasa CGM you cantik, don't you? Clinically, it's not CGM, right? Temperature and then sinuses, semua that, betul tak? Then it's CGM like that. So, and the big message here is, in doubt, that's what Professor Lee used to say, take it out. Without anything, take it out. But you don't have to do a vasectomy without. Don't do a vasectomy. Okay, do not do a vasectomy. So that if you all agree that you should not do a vasectomy, but kalau betul lah cancer, kita buat cancer, kita do a second operation.
So my comment for this basically, to get diagnosed, the first is you should get the diagnosis. So whatever you do, ultrasound-guided biopsy is not gold standard. The excision going to be gold standard. I think after twice you do the ultrasound-guided biopsy, that's it lah. That's it lah. You should go for the excision. That's going to be your gold standard of diagnosis. Get the diagnosis first.
But yeah, patient, we have discussed with the patient and initially she doesn't want.
Okay, then kalau dia tak nak, then kena do betul-betul.
Initially she doesn't want, and then when we repeat the biopsy, cannot get the diagnosis, so at that time the breast is so big, so we try to estimate and get what with CA, then we go for my side. But unfortunately, we have to just really have to do excision biopsy and.
Yeah. So this is a comparative comparison between the pre-op breast and the post-op 6 weeks. Next plan.
Next, okay, we have.
I need.
Okay.
Okay. Okay, I just.
And one.
This is gonna be, yeah.
What should we do next? We have done the local excision. She's triple negative, she modality fine. What do you want to do? Next to, yeah, besides honey. Sorry, I didn't get. Next to.
Cuckoo.
But what questions mentioned the multiple lag with but another thing we have to settle the axilla right now. And given that, I think she is available for
Yeah. Okay, she actually because of triple negative, she went sometime interest.
Okay, so this is all the options.
She
Oops.
went for
What's it
chemotherapy. And complete her chemotherapy, then we go for surgery. The surgery, we have a blood scan with her regarding the option whether, but of course, because she's young, she's modality negative, so the fact is a breast, and she's D3 tumor. The thing is that the D3 tumor, are you going for SRIP or NC? That's my question. So whether I think
we asked Prof. Suniza, Miss Prof. Aisha, regarding Salambi, is there any
So remember that at the global parameter is sentinel liquid biopsy, identification rates and false negative rate. So in this case, you probably remove like half whole breast under the skin. You think you have a successful sentinel biopsy? Most likely not, and then the treatment has been there for 1.5 years. So nobody's going to fault you if you do an exhibit section.
so,
all right.
He's undergoing chemo now, so next will be mastectomy and EC.
So we,
Mastectomy recon, she will decide on the recon.
Okay, so we sent her for genetic counselling and fertility preservation. The result just came back. She is BRCA1 positive, which is 2 days ago, just came back.
BRCA patient and aggressive, but I think
Prognosis is good. So just for everyone, for medullary, 92% is actually triple negative and commonly seen in the BRCA1, but 30% of BRCA1 is medullary and it's actually most of it is lymph node negative and with all the features of aggressive pathologically descriptions, but however, they have a good overall good prognosis.
Yeah. So, all right, thank you, everyone. Thank you, Dr. Nurul and Ms. Juliana. So we're gonna proceed next with our sponsor talk by BD, by our esteemed speaker, Prof. Suniza. In the meantime, if you want to take any tea breaks as well, you might do so.
I don't know that you cannot put that, but I can't see there. That's why I was presenting like. That's why I should here. I should ask lah earlier because I thought I can see.
Right.
Okay, I can start.